Okay. Well, thanks for being interviewed.
Yeah, it's my pleasure.
I guess we could probably take our masks.
Yeah, I think so. That'd be fine. Fine with me.
Fine with me too. Okay. Okay.
Oh,
So, don't be nervous.
no, try not to be.
Okay, it's gonna be fine.
Yeah.
It's gonna be fine. Because
Don't
you've been
hurt
doing
me.
this a long time, so you know
Exactly.
you know what you're talking about.
Yeah.
Okay. So basically, we're doing this as we're studying like critical transitions from. So we've got a mom that starts on antepartum, or a patient on antepartum, and then she has a baby. So the baby comes up in the NICU, and then she becomes a mom-baby patient.
Mm-hmm.
So we're just interviewing, getting feedback from all these different perspectives, and we'll be doing a whole different set of family interviews too, from patient perspective and the dad's perspective. So this is from your unique perspective as the baby doctor.
Yeah.
Okay. So we know that you work on the NICU,
Mm-hmm.
and you're a neonatologist. How
I am.
long have you been doing that work?
So, probably about 10 years as a independent neonatologist. If you count fellowships, more like 13 or 14 years, but yeah. So,
And how long have you been here now?
over 2 years now. So,
It goes by fast.
yeah, it does. Absolutely. Yeah.
I know. And you were in Arkansas before that.
I was. Yes.
Okay. Well, good. And so, all right. So, when you just are reflecting on patients who have transitioned from antepartum into the NICU,
Mm-hmm.
and then the mom also, who's obviously going through all the things she's going through, and dad, what stands out to you? Just when you just think about that transition, what are the big highlighted bullet points that stand out to you?
For the family, or for me, or
anything from the baby, from your perspective, and you're looking in at the baby, the mom, the dad, all the staff. Kind of, what are the big bullet points that stand out as that transition is happening?
Well, I think I think of several things, but the speed at which it happens, is not, it's not going to play around. We just we go straight from the delivery room in most situations to the NICU. I mean, there's times when we have babies that can stay with mom for a little bit or something. So there's that. There's the, from the mom's standpoint, at least just kind of looking at things. I mean, there's a lot of times when she doesn't get much in the way of interaction with her baby prior to coming to NICU, especially if she's C-section or that makes it very difficult. They get to kind of look and maybe touch, but that's they're pretty much in the NICU. And then once she's cleared by OB, she can come up and stuff. So it could be several hours. Sometimes it could be a day or two. Sometimes depending on what's going on. I think I would always imagine that's pretty difficult, for a mom. And for dads, I think it's just there's everything. I think everything about this is very shocking to a dad. I would imagine, if I wasn't a physician, just because guys just don't really just kind of that would be nothing that you could equate that to, so I think that would be that'd be pretty big. On top of all the feelings of now you're a dad, so so there's that. For the baby, I just I think there's again this dramatic entry into the world, and this environment in which there is no real bonding going on or anything like that. It's just you have a critical care baby, and we got that little guy. I mean, there's nothing, and all the things that you would think would be natural from that transition from intrauterine to extrauterine life is not there, because we're trying to stabilize, we're trying to whatever,
Yeah, like
so,
nothing is really normal about this whole process.
Yeah, it's all abnormal.
From a baby coming into the world perspective.
Yeah, exactly.
It's abnormal.
Exactly, yeah.
Including living through it is done. It's what happens up here facilitates that.
Yeah.
But that in and of itself is sort of abnormal.
Yes, exactly.
Yeah.
I mean, it's all abnormal. I mean, it's not. It's very. I think it'd be very. It's a very shocking experience. So.
For everybody.
For everybody, yeah. So.
Yeah. So, okay. Well, let me ask you a couple of other questions because I think it'll help kind of dive a little bit deeper into, from your perspective as a neonatologist, how this all goes. So, like, what do you think are the top challenges or the concerns that families are facing as the baby enters the NICU?
It's the uncertainty. I mean, that's got to be the biggest thing. But it depends on the situation, because it's not a. I mean, there's such a variety. There's such a big spectrum of situations in which babies enter NICU. Some of them are just here because they just have a little bit of respiratory stress and they just need a day or two to transition. And they're fine. There's some that are very edge of viability or have some significant congenital issues that so just I think uncertainty is by far the biggest thing that families have to face, and then just the unsettling feeling of seeing your child in this situation,
right.
And again, I more so for moms because they go through this process of bonding several months before dad does, and so dads, I think that there's this detached kind of like what's going on, and I mean, anyway, I think it's just difficult, from that standpoint. So yeah.
What about, and this might be harder for you to speak to because your work is up here in the NICU, but what about that transition that mom has gone through from being a patient on antepartum, and now she has a baby up here, but she is also still a patient in the postpartum unit. Like, from that perspective, what other challenges or concerns do you think that family's facing, generally speaking?
I think that just the general new set of nurses. I think that's probably some of the biggest things probably, because the docs are going to be the same, the nurse practitioners will be the same. That's from the team downstairs. Yeah. So I think that'll be the biggest thing. Of course, new room, but and some of that stuff affects some people more than others.
Exactly.
It's kind of like I think if you think of some women may not be a big deal. Dads don't I don't think any of us would care really.
But the patient might care a little bit.
Yeah, that's what I'm saying. That's what I'm saying.
And
I think
others wouldn't.
Yeah, exactly. Some moms may be like, okay, no big deal, new room, new set of nurses, I make friends easy, all that kind of stuff. And some of them don't. They've been through a very, very difficult pregnancy and they're, worn out, all that sort of thing. So, yeah.
Yeah, I think that's, very insightful.
Yeah.
Very insightful. So during that critical transition, what are your top concerns?
I think as the doctor of the baby, I think my biggest concern is for the parents to have a accurate understanding of what's going on with with their baby, you know, so depending on what that is, you know, so some of those are very hard conversations, and some of those are very easy conversations. So just kind of having a realistic expectation of what's going on and how things are, you know, what I'm seeing and how things are going. So I think it's the biggest thing. So
yeah, because once you get the baby as your real primary concern. See that you answered a little differently than I thought. You were going to go one direction and you went another. You kind of went with the parents. Because I thought you were going to say the baby and getting the baby stable is your top.
Oh, sure. Yeah.
And you're like, well, yeah, of course it is, but also then there's connecting with the parents and helping them understand.
No, exactly. I mean, getting the baby stable is, but yeah, I mean, you know, but if we're talking about I guess, you know, transition type of thing, and then from that standpoint is how, you know, how to help the parents know what's going on for that baby, and then start to build rapport, start to build a relationship, just in case future conversations are hard to have, you know, or future conversations need to be. So I'm constantly thinking about. I think the you know, I just from doing this for years now, I think that the stabilization part, the all that sort of thing is much easier than how am I going to set this family up for what I anticipate is going to be what I anticipate the hospital course is going to be like. So how do we need to have those conversations in the beginning so that way things will be easier for me or a colleague of mine later on down the road, you know, and stuff. And so that requires a lot of experience, I think, after many years and stuff, and just like, okay, I've seen this before, this is how it's going to go, or this is how I feel things are, and so that sort of thing. So, but yeah, definitely, the baby, we're just trying to stabilize.
Yeah.
So, and then,
but I like how you're talking about it, because it's really from like, not like the baby is its own separate entity, because the baby is clearly connected to the parents. And so really all the work we do here is for the whole family. And we're building relationships. I mean, we have relationships with all these babies, but the real relationships we have because the people we're talking to, and getting to know every day are the parents.
Exactly. So.
Well, good. So, all right. Well, so in all of that experience, how do you feel we can make this a better process?
I've often thought of that. Thought about how you can make that process better. Mainly because if you have a family who is going along, and then things change in the pregnancy that make them come to the hospital and have this delivery or have this baby in a way that they didn't think it was going to happen. I think there's a lot of areas in which we can it's never going to be perfect. I mean, that's the first thing, is I don't it's not one of those things that you could get to the point where there's never going to be an anxiety, or there's never going to be an unknown or anything like that. I mean, that's just, there's too many variables, there's too many anything along those lines.
We positive.
Yeah.